So now we're going to get into mid-cervical instability, right? That's from, let's say, C3 to C7, even C2 to C7, what we're looking at. Here's a video of our DMX that you can see when we start to move it.
Significant instability. You'll see how on flexion it gets much worse, and you'll watch when she goes into it.
So as you can see, we're seeing how that moves and how there's a slippage. Now, how do we measure that? When you come to our office, we use this technology to measure the images, compare it to norms, and the red line shows that there's an abnormality. We can see when I'm looking at the DMX, when to pause it and to measure it, to look for some of these instabilities that could be a problem. We also give the numbers of what the established normal should be, and if you are over that established normal, leading to instability. Now, why is that a problem? Well, let's take a look at what some of the research is. We want to understand what this means to you, right? If we do a DMX and we see these problems, you want to know how this can affect you. What does the research show? How can this be affecting you from a physiological perspective? Dynamic elements, meaning as you're moving, can magnify the static component of canal deformation by ligamentous and osseous pathology, meaning the area of your spinal cord can start to decrease the diameter. And that these motion-related factors, not only do they reduce space, but they can also compromise capillaries and microvasculature that maintain a steady supply of oxygen and nutrients to the spinal cord. That was published in Journal of Neurosurgery in 2015. So if we see instability, not only is it a problem and it can lead to long-term irritation and pain and degeneration, there's all studies to suggest and support that, but it also can irritate your spinal cord. This is why we want to fix this. Now, what about mid-cervical and long-term? Okay, we diagnosed with instability. Here's a study that shows that essentially it means that radiculopathy, meaning the nerve root gets compressed and irritated, is a manifestation of spinal instability, meaning if you're diagnosed with spinal instability and you leave it, it will most likely down the road lead to radiculopathy. That was published in Journal of Craniovertebral Junction of the Spine in 2018. Now, mid-cervical and crashes. We're going to talk a little bit about car crashes because we see a lot of patients in crashes with this technology. In this paper, looked at 692 records were collected, 432 were removed, where we ended up keeping 261 radiographs of these patients. What we found in this study was that the study suggests that the specific forces involved in a crash lead to particular patterns of subfailure instability in female subjects. We found that in this study that car crashes and looking at different vectors led to mid-cervical instability. This was published in Journal of Pain Physician in 2007, and I was one of the authors of this paper as well. Now, mid-cervical spondy correction, when that area is slipped, can we fix that? We want to know if it's unstable and how can we fix that? Well, here's a paper that I was the author of as well, published in Journal of Musculoskeletal Radiology, Improvements in Cervical Spinal Canal Diameter and Neck Disability following correction of cervical lordosis and cervical spondylolisthesis using chiropractic biophysics. Here are some pre and post pictures. On the left, complete abnormal curve, that mid-cervical slippage and instability even on a neutral view, with canal narrowing. On the right, this is how we were able to fix this person, and we did multiple of these, getting it published in a journal. Here's another picture. As you can see, the red line is now more closer to the green line and more aligned with the one itself, minimizing compression of the spinal canal or minimizing the canal diameter. So how do we know that this is abnormal? We do a DMX and we say, this mid-cervical instability is a problem. Like, well, how do you know that's not part of the asymptomatic group? We hear patients all the time like, well, my doc says they think that's normal. It doesn't matter what they think. What matters is what is the actual answer to this. And what we know is we know it's abnormal. And here's how we know. The paper that we did, our study, shows us, we compared it. It's the largest study that compares injured and asymptomatic people looking through all these parameters. And here's what we found. When we look at here, it says table 3, we looked at C2 to C7 translation as well as intervertebral angulation. There's some stuff in here that I'm not going to go over just due to time, where we looked at mid-phase range of motion as well, which is a problem. But what we found is that if you look at this C5 and C6, we found 19% of the symptomatic individuals had instability and only 2% of the asymptomatic. We found at C7 intervertebral angulation, 25% of the symptomatic population had it at one level and only 7% on the other.